morning. I think I'll probably take this off. Good morning, and thank you for the introduction. Today our topic is relapses versus pseudo-relapses, what's going on? And I must say this is one of our most commonly discussed issues in the clinic, and so I'm excited to get to explore it with you this morning. So our objectives will be to define MS relapses as well as pseudo-relapses, review the natural course of MS as it pertains to relapses, and then finally we'll discuss some approaches to relapse management. So an accepted definition of relapse is the following, which you all can hopefully read, but it's essentially a monophasic or isolated discrete clinical episode where the patient reports symptoms and there's some objective findings on exam that we think of as typical for MS, and I'll give you some examples in a little bit. And that reflects some kind of damage either in one spot or multiple spots to the central nervous system, typically developing over hours to days and lasting at least a day, but typically much longer than that, with or without recovery and in the absence of fever or infection. And I've highlighted that last caveat, and we'll kind of go into a little bit more depth on that topic. Please note that we tend to use the term relapse, exacerbation, attack, or even sometimes just episode synonymously in this context. So when we think of MS relapses, they tend to follow a particular pattern or affect a particular part of the nervous system. One common one would be optic neuritis, where a person might develop some blurred vision, typically on one side, occasionally on both sides, and often associated with pain or soreness with eye movement. A brainstem attack that might include numbness on the face or weakness of the face or double vision or other types of symptoms. Transverse myelitis or an attack of the spinal cord, which can lead to numbness or weakness in the arms or legs. A cerebellar attack, the cerebellum is this part of the posterior or back part of the brain that is responsible for balance and coordination, so those things can be affected. Or a cerebral attack, which might affect things like language or cognition, or lead to impaired mobility on one side of the body. On the left-hand side, you see an MRI of a person's neck or cervical spine, and this person has MS, and they have some characteristic plaques or spots in their spinal cord. This is what MS does. It causes inflammatory damage to various parts, including the spinal cord, and that can lead to MS symptoms. On the right-hand side, you see a depiction of a neuron with the normal neuron appearing on the left with its cell body at the top, and then the projection or axon going down. The axon is surrounded by a myelin sheath. The myelin, as many of you already know, is that kind of insulation that allows the nerve impulse to be transmitted in an efficient and quick manner. With MS, the presumed target of the autoimmune inflammation is that myelin, and what what typically happens is that when that myelin gets damaged, you don't get as efficient or quick of a transmission of that nerve impulse. So when that happens the first time, when there is an initial attack of a specific area in the nervous system leading to dysfunction of that area, we call it a relapse. When it happens when there's pre-existing damage that a person has perhaps recovered from, and then at some point later on, when normally there's that signal getting through pretty well, but then something happens, and for a period of time, that signal is not getting through as well because that nerve is still intact but damaged. That's kind of the main distinction we think of between a relapse and a pseudo-relapse. Some things that affect a relapse, how severe it might be, would include the size of the lesion or lesions, how destructive it is, and the location of the lesion. For instance, in the spinal cord, we tend to see more severe symptoms than it might be for certain parts of the brain. Also, the burden of pre-existing damage. So this kind of gets into the concept of neurological reserve. So if you have same type and same size, same destructiveness of a lesion in one person who has a greater pre-existing burden of disease compared to somebody else who has very minimal pre-existing disease. That person who has less pre-existing disease might be able to better withstand that particular insult and might not experience quite as severe symptoms as that person with a larger amount of pre-existing damage. We also think of short-term treatments, specifically high-dose steroids affecting relapse severity or really more longevity, and we'll get into that in a little bit. And finally, disease-modifying therapies can influence relapse severity. Pseudo-exacerbations now. Just if we can pause for a moment on this whole, pseudo thing, which really kind of conjures up a, something fake or not real, or it's really all in your head. But the truth is, it's very real. These are neurological symptoms that a person is experiencing. But the distinction is, as I've kind of alluded to before, is there's already a previous deficit, but at the time or immediately prior to the time, the person wasn't having symptoms because that nerve impulse was getting through for the most part. But then due to some, typically we think of it happening in the setting of a systemic disturbance like an infection or overheating or stress or sometimes even just a change in medications, that thing that had previously caused a deficit, that area of damage, but that was no longer causing a deficit, then for a period of time, that deficit reemerges. And in addition to that particular symptom, a person might experience more generalized symptoms or systemic symptoms like fevers or whole body weakness or cognitive slowing or fatigue beyond what they normally experience. Here's a little Venn diagram that I made up to kind of help us tease apart things that are associated with relapse versus things that are associated with pseudo-relapses. And as you can see in the middle, neurological symptoms like numbness, weakness, blurred vision, dizziness, gait impairment, those can be common to either of those. So just the description that we hear on the phone, oh, I'm feeling weak or I'm having blurred vision, that doesn't necessarily help us until we kind of delve a little bit further into the story, whether it's a relapse or a pseudo attack. A relapse, by definition, really should be brand new symptoms that a person hasn't experienced before, whereas a pseudo attack is really, as I said, a replay of prior symptoms. The relapse tends to last on the order of weeks to months, whereas a pseudo relapse tends to be more short-lived. A relapse doesn't occur with fever infection by definition, although I'll show you a slide in a little bit that kind of muddies the waters a little bit there. Whereas a pseudo-exacerbation, very frequently we see in the context of an infection or fever or increase in stress. We generally think of relapses happening to people, maybe right at the beginning of their kind of MS trajectory, before they've been diagnosed, at younger ages, and in the relapsing form of the disease. Whereas pseudo attacks tend to occur more when people have had the disease for some period of time. Maybe they're in the progressive phase as well. As far as disease modifying therapies, a relapse may occur if a person, for instance, is not taking any disease modifying therapy, or if they're not on one of our more highly efficacious treatments. Whereas with a pseudo exacerbation, the disease modifying therapy doesn't really matter. And in fact, if a person is on a highly effective treatment and is coming to us or calling us with symptoms, we're already starting to think, well, we know these treatments are very effective at preventing relapses, but they don't really do anything for pseudo relapses. Therefore, it's more likely than not that it's going to be a pseudo relapse. So what is the relationship between infections and exacerbations? This is actually between infections and MS in general is kind of a big topic. And I'll just say for a long time, researchers have been looking for a relationship between MS and particular infections, or the susceptibility to MS and particular infections. And I believe you'll have Dr. Corboy talk to you in a little bit about new data on the relationship between Epstein-Barr virus infection and the development of MS. But this specific slide is trying to assess, and other studies have also looked at, whether infections in a person who already has MS can lead to more exacerbations. So this was an observational study from actually a little while back, that had a lot of patients enrolled and followed them for a long period of time. And what they found was a greater than twofold increase in risk for exacerbations around the period of an infection compared to outside of that period. And so this is interesting. And you might say, well, Dr. Gross, didn't you just tell me that infections are more associated with pseudo-exacerbations than with exacerbations? So what's going on here? Well, I will say that in this particular study, when they looked at MRI activity in this kind of period around infections versus the period not around infections, there was no difference between active MRI activity in those two periods, which to me suggests that perhaps what they're seeing, this increase in exacerbation rate, is actually more pseudo-exacerbation rather than exacerbation, i.e. not new damage to the nervous system, but rather a replay of pre-existing damage. And this is another question that comes up a lot. Does stress cause exacerbations? And this is a meta-analysis or a study of studies that showed that there was in fact a relationship in most of these studies between stressful life events, not associated with physical trauma, but just psychological trauma, psychological stress, and exacerbations in multiple sclerosis. And again, you might ask, well, didn't you just say that stress is more associated with pseudo-exacerbations, not with exacerbations? So what's going on here? And then again, I might suggest this particular study didn't look at MRI activity per se, but what they're calling exacerbations may in fact have been pseudo-exacerbations all along. And one interesting thing that we note in clinical research involving MS is that if you look just at the placebo arms of clinical trials going back 20, 30 years for multiple sclerosis, the exacerbation rates in, again, the placebo arm, not receiving any type of active treatment, goes from initially being over 1 relapse per person per year to under a half relapse per person per year as time went on. And so what's that all about? So some of that could certainly be that we're designing trials differently. We're enrolling different types of people in the trials now compared to before. But there could also be this idea that, maybe back in the day we weren't as we weren't as, I don't want to offend anybody who might have been practicing back then, but we weren't as good about distinguishing between pseudo-exacerbations and exacerbations, and that maybe some of those relapses, quote unquote relapses, were in fact pseudo-exacerbations. But that's a hypothesis. So when somebody calls us with symptoms that are neurological symptoms that are concerning, what we try to do is evaluate them ideally in person. We can certainly, we can and certainly do virtual and telephone encounters with patients, particularly ones who live far away. But ideally, especially where it is important to do a neurological exam, the in-person is preferred. And then following that, we will typically get some type of neuroimage, so MRIs, perhaps the brain or orbits or cervical or thoracic spine, really depending on what type of symptom the person is describing. And then there's often a search for infection because, again, I said one of the key triggers for pseudo-exacerbation is the co-occurrence of infection. And so we might order things like urinalysis, urine culture, chest x-ray, perhaps even stool tests or examining the skin for rashes. Blood tests can also sometimes be useful, either to look for blood infection or sometimes as indirect evidence of treatment effect. So for instance, if a person is on an anti-B cell treatment, you could look at their B cell counts and then from there surmise if they say have B cells where you wouldn't have expected them to have that because they had recently gotten for instance, their treatment, and you would have expected that the treatment would have depleted those B cells, but they're in fact still there, then maybe that gives you a clue that the treatment is not working the way it's supposed to work. And therefore, perhaps this is new inflammation rather than a pseudo attack. But again, that's a series of steps, and that's kind of surmising, and you have to take it with all of the other clues that you have. So I'm going to give you a case. This is a 56-year-old woman with secondary progressive MS who calls our clinic to report symptoms. She says that over the past 3 days, there's been an increase in leg weakness. Normally, there is some leg weakness, but she can take several steps with a walker, and now she finds herself just not being able to get out of the wheelchair. And she's also noted a discoloration and foul smell to her urine and asks about the need for corticosteroids. So we have her come in. There's an examination that showed a greater amount of weakness in the legs than on prior exams. And because of, not just because, but especially because she reported some foul smell and discoloration of the urine, a urinalysis was performed, and that showed a urinary tract infection. So an antibiotic course was started. And within a week, the person was back to their normal level of function. So that really is a kind of a classic example of a pseudo-exacerbation, because there was the co-occurrence of this other systemic disturbance, urinary tract infection, and treating that thing led to improvement of the neurological symptoms in pretty short order. I show this slide, which is something that you all have seen, I'm sure, before, mostly to indicate that over the person's life, MS, the biology does change, and especially when you look here at the bottom in terms of MRI activity, you tend to see it most early on in the disease course and less as time goes on. And often that new MRI activity leads to these spikes in disability, which we call relapses. And then over time, those relapses might become less frequent and stop altogether. And so we know that, again, going back to the kind of general demographics or characteristics of a person, as time goes on and a person has MS for year after year, that we generally think, just based on the natural history of the disease, that they're less and less likely to have a new inflammation of the type that can be seen on MRI, and more likely, if they're going to have some temporary increase in symptoms, that it might be more likely to be from a pseudo-exacerbation. Disease-modifying therapies, there are many of them now, and they pretty much all reduce the risk and severity of relapses, and many also improve the recovery from relapses, and they prevent new MRI lesion formation. That's really what led to them being approved for use in multiple sclerosis. They do not, however, we think, impact the occurrence or recovery from pseudo-exacerbations. And so, to me, distinguishing between a relapse and a pseudo-relapse really has a big bearing on whether the current DMT status is the optimal one. So if we think that the person is having a new inflammatory event of their central nervous system, then perhaps their current disease-modifying therapy is not cutting it, and we should be doing something else. Whereas, again, a pseudo-exacerbation, we wouldn't expect any difference regardless of the particular disease-modifying therapy, so changing that around probably won't really have an impact. This is a very non-scientific estimate of the ratio of exacerbations to pseudo-exacerbations that we tend to see at our center, the exacerbation being the small pie slice in blue here, and the pseudo-exacerbations being the much larger pie slice in red. Again, very non-scientific. I'm not citing anything because this is really my own anecdotal recollection of things, but I imagine other providers will also back me up on this. When we talk about treatments, and hopefully I have a few more minutes. Great. Yeah, so when we talk about treatments of relapses, really the mainstay when we talk for the short-term treatment of relapses is high-dose steroids. which traditionally was given intravenously, but increasingly now we're starting to use oral preparations of high-dose steroids. And then these other options are sometimes used by some providers. I won't go into too much depth, but there is adrenocorticotropic hormone, or ACTH. There's intravenous immunoglobulin, or IVIG, and then there's plasmapheresis or plasma exchange. The optic neuritis treatment trial was one of our earlier pivotal trials that kind of really established how we treat these types of attacks or exacerbations. And this wasn't specifically limited to people with MS, but some people did end up getting MS. And it was looking at optic neuritis and divided participants into 3 groups, either receiving a lower dose oral steroid followed by a taper, or high dose IV steroids followed by a taper, or placebo. And the upshot was actually, regardless of group, many patients experienced recovery of their visual symptoms within a couple weeks. And after 4 to 6 weeks, most patients did have a good recovery, although you could still see improvement all the way up to a year. And then when you broke it down by the different groups, specifically between the high dose IV group versus the lower dose oral group, you did see a faster recovery with visual parameters, especially within that first 2 weeks after the episode. And by month 6, there was a difference in certain things like contrast vision, visual fields, and color vision, with improvement seen in the IV arm compared to the lower dose oral arm. But actually, acuity, or how well you could see on the eye chart, there was no difference between the groups. And by the end of the year, there was really no difference in any of these visual parameters, regardless of the group. So this and other studies, but in large measure, this study really helped to solidify this concept that steroids helps to accelerate the recovery, although most people tend to end up in the same place whether they got the steroid or not. And then, fortunately, we have had to hospitalize people for MS exacerbations a lot less commonly than we used to. But still, especially when people have severe attacks, they'll need hospitalization. And there have been randomized controlled trials that I cite here that looked at treating people who may not have had a good response to steroids initially, treating them with plasmapheresis, and randomizing them to that versus a sham procedure. And there seemed to be a benefit with plasmapheresis for these patients who had a more severe attack. So that is still sometimes used, particularly in these more severe attacks. And as I mentioned before, we do now tend to use a lot of oral steroids as opposed to IV steroids, because there have been trials, and there's a study of those trials that I've cited below, that pretty clearly demonstrates that doing the oral is not inferior to doing the high dose IV. So they're both high dose, but one is by mouth versus the other being IV, and the one by mouth is going to be a lot more convenient in many cases because it can be done at home, with the side effects being pretty similar between the two, where I think just insomnia might be a little bit more with the by mouth. As far as treatment of pseudo-exacerbations, because as I said, that tends to be the thing we see more commonly, there really hasn't been that much literature out there on the optimal way to treat them. But kind of, what we tend to do is, try to identify what contributing factors there are. So for instance, if there's a clear infection, we can give antibiotics. Since fever and elevated body temperature is known to make that signal not go through as well, if there is fever present, taking medications like Tylenol or acetaminophen and or non-steroidal anti-inflammatories or NSAIDs to reduce that fever may also help the neurological symptoms improve faster because the body temperature is lower. To the extent that there is a worsening or recurrence of mobility or function in the arms or legs, physical and occupational therapy might be useful. As I mentioned before, with stress, perhaps being a more of a cause for pseudo-exacerbations, I think would be very interesting to know whether certain stress-reducing techniques would help to reduce the frequency of these attacks or improve the recovery. So things like acupuncture or mindfulness or meditation, things of that nature to induce relaxation. Whether those actually would make a difference, but we don't know at this point. So in conclusion, I'll say that it is very important for us to try to distinguish between relapses and pseudo-exacerbations, mostly because there is a difference in terms of how we would treat them in the short term and especially in the long term as far as disease-modifying therapies. The symptoms, numbness, weakness, imbalance, so forth, may be overlapping between the two, but there are certain features that might point more to one than the other. For instance, whether a person is having other infectious symptoms or whether they've had that particular symptom before. And when we're not sure, we often will do testing after the evaluation. And when you're not sure, please don't hesitate to call us, reach out to us through the portal, and then we can kind of try to come up with a plan from there. So with that, I'd like to thank you for your attention, and I think we'll take questions in the Q&A session.